Okay. We only have one round to go through. So, one other thing when we start this, wait until I say what's the answer. Don't shout the answer. Let people think and process. Give them a few seconds so that everyone has a chance to think before we answer it. So, okay, we're just going to go in order through. Okay, I thought that one. Let's try this again. I know, you already got one. Okay. What's the GFR we classify mild chronic kidney disease? What's that magic number? 60. 60, very good. Okay, also, acute versus chronic is just a matter of time. So if you have acute renal failure, either you get normal or you go to chronic. The only two things that can happen. Okay, there we go. Okay, post-renal, acute renal failure. Remember, what's the answer? Anything after the kidney. I hate this thing. Hold on a second, I'm switching over. Hang on a second, I'm switching over. Okay. Okay, anything after the kidney, so any blockages in the ureter, bladder, or urethra is post-renal. What three hormones, wait 5-10 seconds, don't shut them out, are hormones that the kidneys are responsible for? There's only three major ones that we've talked about. Okay, what is one? EPO is one. What's another one? Renin. What's the last one? Vitamin D activation. Okay? It's got to activate vitamin D. You don't have it, you don't get it. Okay, what's the major difference between nephrotic with an O and nephritic with an I? Okay, so remember, the O has protein in it with the O, pro. The I is inflammatory, and that's blood. Okay, what are the two barriers? Don't shout them out. There are two barriers we have to filtration in the kidneys. There's only two. Okay. What is one? Size of the particle and charge. Okay, charge of the particle. Okay, don't shout it out. What substance affects the afferent arterioles? Okay, this is going to be an example of a thinking question on your exam. If I tell you you're going to block something, what's going to happen to that afferent or efferent arteriole? If you block it, so what is the substance that affects the afferents? Norepinephrine. Norepinephrine does what to those afferent arterioles? Constriction. What is on the efferent side? Angiotensin 2. And what does that do to the efferent side? Constriction as well. So if I tell you I'm giving you a drug that's going to block the effects of norepinephrine, what is going to happen to the afferent arteriole? Dilate. And when you have dilation of that afferent arteriole, look at that pictures and know what happens to renal blood flow, what happens to GFR. Okay, that's a thinking question. Why you give certain drugs, you gotta be careful, okay? Okay. Okay, what is the relationship, don't shout it out, between GFR and creatinine clearance? So, this is a Jeopardy, it's not a Kahoot, but we're talking about creatinine clearance to make sure you understand what clearance is. What's the definition of clearance? The amount of solute rendered free of a substance in 1 minute is your creatinine clearance. What can we clear? So how does that number correlate with the GFR? Do they both go up together or are they opposite? Inverse relationship. They are opposites. Okay, as the GFR goes down, it means our kidney function is getting worse. We can't clear as much anymore, so the creatinine goes up.
GFR and creatine clearance would be directly proportional, right? Creatine level would be
the level is what we're looking at. The creatine clearance, actually what we look at in the blood is the creatinine. Okay, what is fractional excretion? Only if I mention it, but that most of them just read. If I told you don't worry about it, then it's not going to be on your test. So only as they relate. I'm not going to put any specific ones on there, but as they relate to the kidneys and how they help reinforce an idea. Okay, so what's fractional excretion? So the fractional excretion, remember, it's a proportion. What was dumped into the Bowman's capsule? What's that called? Filtered load, what was dumped there, versus what's the other number that comes out? Excretion rate. Okay, put those together, you get fractional excretion and what was left in the urine, what percent was left in the urine after it's been filtered. Okay, solute concentration as a percentage of the filtered load. Okay, so fractional excretion for sodium is 1 to 2%, meaning 1 to 2% of that filtered load is still going to remain in the urine. Which one was special with fractional excretion? Has very wide ranges of excretion. Potassium. Okay, remember, potassium we don't like in high values. We have to get rid of it fast. So potassium, we can alter that excretion depending on how high the potassium is in the blood. We can dump more out. What's that called? When you put a solute into the tubular system outside the Bowman's capsule. Secretion. It's filtration in the very beginning, secretion if it goes in afterwards, and what is it called when we take stuff out of the Bowman's capsule to put it back into the blood? Reabsorption. Where does absorption occur? Intestines, very good. So where's the bulk of sodium reabsorbed? Proximal tubule. So as you are studying renal, just like you're studying the GI system, start by sections. Go from the nephron, glomerular capillaries in the Bowman's capsule. Then the next section is the proximal convoluted tubule. What happens here? What ions are moved at this section? Then go to the loop of Henle. What happens here at the loop of Henle? What happens in the descending loop? What happens on the ascending side? Then go to the distal convoluted tubule. What happens here? So we can break it up that way. So again, bulk is proximal. Where do potassium, wait 5 seconds before you answer, where do the potassium-sparing diuretics have their effect? Remember, there's 4 spots for diuretics. We talked about carbonic anhydrase inhibitors very briefly, but we don't really use them for overload. But potassium sparing, where do they occur? The common collecting duct, late distal tubule, similar thing. That's where potassium sparing effects have their effect. Why? What hormone is responsible for that? Aldosterone. What does aldosterone do normally? Where does it push sodium? Into the tubular fluid, into the urine. What is it pulling out? Potassium. That's why it's potassium sparing. These are very weak diuretics because they happen so late in the nephron. So we don't use them for if you came in with heart failure, I'm not giving you a potassium sparing diuretic because it's too weak. So we give them the loop diuretics or the thiazides and make sure you understand where they all work as well. They work in areas that have the receptors. Yeah.
Just to clarify, you mean aldosterone pushes sodium in the blood and potassium in the fluid, right? In the urine. Yeah, the urine.
Yes, it reabsorbs sodium with water into the bloodstream and pushes potassium into the urine. That's the job of aldosterone. The aldosterone antagonist, like spironolactone, shuts the sodium reabsorption, therefore potassium stays in the blood. So you lose sodium into the urine and water goes with it, weak diuretic. What is the major effect of antidiuretic hormone on the kidneys? So remember, there are 2 receptors. Make sure you know which ones in the kidney that has the major effect that we want. So what does ADH do for the kidney? That's one of them. But now, when you say water retention, with ADH, it's very special. What is special about it? That's the channel that it uses, aquaporin. It's water by itself. It's free solute water. There's no sodium in it. Remember, when sodium moves, water is going to go with it. With ADH, it's only solute free water that's moving. There's nothing else in it, so it's just plain water by itself. Where does it have its effect? ADH, it's a hormone. Right at the end. Convoluted tubule, late distal and common collecting duct. So, solute free water through your V2 receptors. The V1 causes vasoconstriction. Okay? But still all vasopressin. When we have low effective circulating volume, severe dehydration, you're bleeding out, we have low volume in our blood, what are some of the things that our body is going to do in a response to this low effective circulating volume? There's 4 of them. Okay, so think about it for a second. What is the first thing that's usually going to happen in the kidneys? What senses low effective circulating volume? Macula densa. And what does macula densa going to secrete in response to the low effective circulating volume? Renin. Just know that renin ends with aldosterone. We'll figure out all the rest of the pieces tomorrow or next week. What else can we do? Vasoconstriction. And what system is responsible for vasoconstriction? Sympathetic. So we have sympathetic responses. That helps with low circulating volume. What else? Aldosterone, what's that going to do? Yep. And fluid retention being those Starling's forces. So remember the push and the suck? It all shows up again in the kidneys. So activation of your RAS system is the aldosterone with the renin. Sympathetic nervous system will kick in. ADH secretion to increase our blood volume. Remember, it's anti-diuretic, so we're going to retain that water, increase the blood volume, increase the pressure, and then fluid retention. So before we go into this one, what is the major response that we really can do with high effective circulating volume. Do any of those markers that we just learned about do anything in high effective circulating volume? No. What's the really way we can do it? AMP, diurese your patient. Get the fluid off. And diuresis through atrial natriuretic peptide, BNP, brain natriuretic peptide, provide a natural natriuresis through sodium. That's why it's natriuresis, the Na. Normally we talk about diuresing. Diuresing a patient is an umbrella term, but natriuresis means we're altering that sodium. So next question, how do we stimulate reabsorption of calcium in the distal tubule? Remember, calcium is under the influence of other things. So what are some other things that are there to help with calcium? Parathyroid hormone is one of them. Vitamin D is the big one. And the last one is a tricky one. Thiazide diuretics can also cause high calcium because remember where the thiazide diuretics have their effect? That's where calcium absorption, reabsorption happens there as well. So it alters both of them. Okay, you have our following lab values. What is the compensatory mechanism? So think about it. First, work out what the primary cause is and what is the compensatory mechanism. So all acid-base problems, what do you start with? The pH. Is this pH normal? It's acidic. Okay, so we know the pH is acidic. What is the CO2? High or low? High. When CO2 is high, what does that mean? Acidosis. HCO3, the bicarb, is that high or low? A little bit high. So we have to match, right? So what is the primary cause here? Respiratory acidosis. So what is the compensatory mechanism? What is our body trying to do to offset it? We're increasing our bicarb to offset the acidity. That's the compensatory mechanism. Okay? Everyone okay on that one?
What are the normal ranges again for CO2 and bicarb?
CO2 is around 40. Bicarb is 18 to 23. And you'll have the ranges. I'll make sure you guys have your ranges or the AA one. Yeah, you have it?
Different ranges?
It didn't work though, right?
It didn't work?
I think it worked for you.
Oh, just kidding. I didn't read
It didn't work? Okay. So yours didn't work? Okay. I think on the exam I have the real ranges in there as well, so you'll have the ranges.
Are they going to be in the ranges
In the question. I'll make sure tonight. Okay, the next one's also an acid-base one. Okay, give yourselves a few seconds. I'm not going to help you with this one, but again, it has the ranges there. I'm sorry, CO2, bicarb is 22 to 28, not 18 to 23. So, sorry. 28. Okay, so pH, acidic or alkaline? Alkaline. So we know already we're going to have an alkalosis is the answer. Now we've got to figure out, is this metabolic or is it respiratory? Which one also fits the narrative? Bicarb. Is bicarb high or low? High. So we have an alkalosis and we have a high bicarb. So what is the acid-base disturbance in this one? Yep. Metabolic alkalosis. Now, the pH is still high. Now, if I said the pH was like 7.45, 7.46 in this example, but the CO2 is still normal, the CO2 would have to change for there to be compensation. There's no compensation going on right now because the CO2 is still normal. So how would you compensate for a metabolic alkalosis? So we need a respiratory acidosis. So what do we do to our breathing? Hypoventilate, just slow down our breathing. And I'll get rid of it. Okay? Okay, moving on to the GI ones. What is the actual clinical definition of digestion? Okay? Okay, so what is digestion? Breaking down macromolecules into smaller ones. That's all digestion is. What layer of the GI tract is responsible for increasing surface area and various endocrine and exocrine secretions? So make sure you know the 4 layers of the mucosa, the GI tract. Mucosa, submucosa, myenteric plexus, and then the connective tissue at the bottom. So what layer has this in it? Mucosal layer. It's got mucus in there. The submucosal layer, what's special about the submucosal layer? What does it have in there? Blood and vessels. Okay, so if you erode out and you start bleeding ulcers, we know you eroded the full thickness of the mucosal layer, and now you're getting to that submucosal layer. Make sure you also know the different layers and what plexus are in each layer. Is it a motor plexus, or is it the myenteric one, or is it the other one that has more of the exocrine, endocrine control? Okay, what nerve is responsible for the lower GI system, not the upper? Okay, there were 2. What controls the upper vagus nerve? What's the lower GI? S2 to S4. Okay, that's the innervation for the lower GI system. Okay, wait a second before you answer. What is first pass metabolism? So, what is first pass metabolism? Liver. So, you eat something, you have a sandwich for lunch, and you have all this glucose going into your bloodstream. When you absorb these nutrients, what is the first blood system that all these things drain into? The hepatic portal vein, the portal system. Everything from the GI system, vascular, that's absorbing all that food, the nutrients, goes into the liver first, metabolizes, then gets out, inferior vena cava, and then up to the heart and goes to the system. So it goes out faster. So first pass metabolism, anything through the GI system has to go through the liver first. What is the effect of histamine in the GI system? Not allergies. So histamine with the GI system, what's histamine going to do? Increases gastric acid secretion. Okay? Okay. It's a direct effect right on those cells to produce hydrochloric acid, and then you get your gastric acid. Okay, next one, think about it. What are the 3 phases of deglutition? What is deglutition? Swallowing. So there are 3 phases to swallowing. Okay, what's the first phase? Oral. What's special about that one compared to the others? Voluntary. Okay. The next phase, laryngeal. Last phase, esophageal. Okay. Buccal, just chewing. The first initial act of swallowing is voluntary. After that, it's all involuntary. So just like you study the renal system, the GI system the same way. To start, okay, I'm eating a piece of food. What does this food happen in my mouth? What happens in my mouth? We swallow. Esophagus is just a tube. Stomach, what is my stomach going to do to that food I just ate? Yep, let it sit there. It's like a rock tumbler. It's going to grind it up, get it smaller. And then that food eventually going to go to the duodenum. What happens? What's special about the duodenum? They go through the small intestine, large intestine outside. Talk about liver, pancreas, gallbladder, what they do. That's really it for the GI system. Just think about it that way. The stomach secretes intrinsic factor. Why is intrinsic factor important? So, what is intrinsic factor used in? What's important? B12. You can't absorb B12 if you don't have intrinsic factor. And it occurs in the terminal ileum. So, if a patient you're seeing has had gastric bypass, you have to find out from the patient what type did they have. Because some of them will cut out the terminal ileum, and if that happens, they're not going to absorb B12. They may have some anemias because of the low B12s. Why is prostaglandin E2 important? Remember, this is about a GI question. So in a GI situation, why is prostaglandin so important? Okay, why is prostaglandin important in the stomach? What does it do? It's that barrier. It helps the stomach from eating itself. It's protection. That bicarb layer has prostaglandins in there. What medicine can you take over the counter that's going to inhibit prostaglandin formation? Acetaminophen. Not acetaminophen. That's ibuprofen. Yeah, but acetaminophεν's Tylenol. It's not an NSAID. Tylenol isn't. But Advil, ibuprofen, those are NSAIDs. And they will... What? NSAIDs, yes. They block it, so if you're on like Aleve or naproxen, those things for a long period of time, you may have some GI upset because that's going away. Yes? What? Yeah, mucosal layer. But just the NSAID itself doesn't have the effect on the stomach itself because it gets in the system, blocks prostaglandins, which then don't fill that mucosal barrier. So it's not a direct effect. Yeah.
So acetaminophen will not do it?
Acetaminophen is Tylenol. It's not an NSAID.
Isn't it a prostaglandin inhibitor though?
Yeah.
It could be. I mean, yeah, but yeah, you're right. So it does do that, yes.
It does it too? Okay.
But they're not considered an NSAID is the main thing. Okay. So, prostaglandin, we know it's in the mucosal barrier. It's a direct antagonist of histamine. What does histamine do? Increase the gastric acid. Helps decrease acid in the stomach. So if you don't have the prostaglandins, acidity goes up, mucosal barrier gets weakened, and you can start getting some ulcer, gastritis, some irritation in the stomach lining from this barrier being weakened. And histamine going crazy. What enzyme is responsible for breaking down proteins? Okay, proteins. What's the enzyme? Pepsin. What's special about pepsin? What is pepsin normally found in the stomach as? Pepsinogen. And what is the stimulus for it to become pepsin? pH of the stomach. As acidity drops because we ate something, obviously we're going to be digesting something, we need pepsin to be active to start breaking down the proteins. If I'm not eating anything, my pH is going to go back up because I don't need acidity in my stomach. There's no reason for pepsin to be activated. There's no food there. So originally pepsinogen, pH drops, pepsin.
What is the pH in a fasting stomach?
I don't know exactly. I know it gets around 5 when you start eating things going lower. I think it's around 6, but it's still acidic, obviously, normally. What ion is responsible and really needed for the co-transport of nutrients, glucose, and amino acids in the intestines? What do you have to have all the time? And what goes along for the ride? What's the answer? Sodium. Sodium has to go along for the rides. This one, don't worry about. Okay, this one was from the beginning. What vitamins are water soluble? Yep, just remember that. Okay, your water soluble ones are vitamin B and C. The opposites ones are fat soluble or ADEK. Just remember one of them. Just remember B and C are water soluble, and then everything else you know is fat soluble. Okay, what vitamins are produced in the large intestine via bacteria? So we have to have these there in order to get this vitamin. What vitamin is this? K. Some B's, but mainly K. Okay, what are some examples of atherogenic lipoproteins? These are the ones produced by the liver that have high amounts of cholesterol in them, and they can cause plaques to form. So the APOs, if I would have to mention apolipoprotein for ApoB or ApoA. I'm just saying lipoprotein, which is VLDL, LDL. So easily remember this too. Just know HDL is the only good one. Everything else is atherogenic. As long as you understand HDL, everything else is atherogenic. Only HDL is the one that the scavenger is going to remove them. Now, so a question up here, not a question, but a comment. The question asked for lipoproteins, not apolipoproteins. Okay? The apolipoproteins are like the little hats that they wear. ApoB is on what?
That's the HDL. No, that's the fat soluble.
That's your LDLs, has ApoB. What does your HDL hat is, apolipoprotein? A. So the apolipoprotein is not the same as your lipoproteins. They are related, but so make sure you read the question. And the last one. Oops. Pancreatic juices. What substances do pancreatic juices break down? There's a couple of them. So think about it. So it's going to break down. Oops, what happened here? There we go. Proteins, nucleic acids, and fatty acids. Amylase is in the mouth also. That's why it's not really a pancreatic juice per se. Proteins, nucleic acids, and fatty acids are really what the pancreatic juice is going to break down. That's it for the review. You guys want to start tonight at 7 or 8? It doesn't matter. 8? Okay, I'll do the same as last time. Otherwise, again, know the definitions, know the afferent, efferent, arteriolar stuff, metabolic, and the acid-base balance stuff. Know where electrolytes are absorbed, what parts of the nephron. The GI stuff, again, straightforward. Just think about you eating food, what happens as it goes through the entire system. That's the way to study that stuff. Otherwise, I'll see you guys tomorrow. Good luck studying tonight.